Friends, this is phacoemulsification of a hypermature Morgagnian cataract. Let us observe the surgical steps. This is the main incision. It's a 2.8 mm incision on the posterior aspect of the limbus. And now, this is a paracentesis on the right side of the main incision, about 2.5 clock hours away. And now I want to stain the anterior capsule of the trypan blue dye underneath an air bubble. Here goes the dye. The dye should touch on all parts of the anterior capsule. The dye is washed out. The patient is under topical anesthesia. We can see the milky appearance, homogeneous appearance of the cataract, and we can make out what will happen as this is a paracentesis on the left side of the main incision. Now what will happen as the anterior capsule will be punctured? See this. Milky fluid comes out. And now what to do? In hypermature Morgagnian cataracts, we can aspirate the milky fluid just through this cleft in the anterior capsule. We don't have to convert it to a mini-rhexis in case of hypermature Morgagnian cataracts, but in intumescent cataracts we must convert it into a mini-rhexis before aspirating some cortical matter. And now this capsular tag is held with a utreta and a continuous curvilinear capsulorhexis is performed. In hypermature Morgagnian cataracts, we must be very slow while pulling the capsule. There should not be any jerky pull. Should be a steady, gentle pull. Rhexis is done, and now how to manage the nucleus. Hydrodissection is not required, so the tip of the Phaco handpiece is introduced into the anterior chamber, Bevel-Down. Now how to hold this free-floating nucleus? See this. You have to hold the nucleus Bevel-Down. Bury the tip Bevel-Down. Go towards the opposite equator. Try to divide the nucleus into two equal halves. The chopper supports the nucleus, and as you go near the opposite equator, you divide the nucleus. Here I hold one heminucleus and separate it completely. And now again Bevel-Down, go through the nucleus for a distance, and now hold it very firmly, and now chop it. You cannot hold such free-floating nucleus with bevel up. It will just run away here and there. So this is the key. To hold the nucleus, the Phaco tip should be Bevel-Down. Go through the nucleus for a distance, and then use vacuum to hold the nucleus firmly and then chop the nucleus into fragments. In all cases are not as easy as this case. Sometimes the nucleus is very much stubborn and leathery and doesn't want to give in, and very difficult to divide the nucleus into fragments. But remember one thing, there is a way. For every case there is a way, and we have to use our common sense to find that way. And in this case I found that there is no joinular weakness. I can see the posterior capsule is far behind, so I have decided to emulsify the nucleus, but I have decreased the parameters at this time. Phaco power was 60% in this case, flow rate was 40 ml per minute, and vacuum was initially 400, but at this time it is only 200. However, the antechamber is very stable, the posterior capsule is far behind, and I could emulsify the nucleus very comfortably. Friends, this is an unedited surgery, and the aim is to inspire you to ignite the fire within you. There is lot of hidden potential in a human being, and once that hidden potential is awakened by inspiration, one human being can support many human beings. Now the cortical cleanup is being done. It doesn't matter what you use, whether Simcoe or bimanual or coaxial IA. The aim is to clean the cortex very nicely. The patient is not going to ask you which instrument you used. The patient wants to see clearly. Whatever you use, the cortex has to be removed very nicely. This is a hydrophobic acrylic monofocal clear intraocular lens, and the lens goes into the capsular bag. Now in this case I want to show you something. There's lot of visco sticking to the corneal endothelium. How to remove that? Simcoe has on irrigating port and on aspirating port. What I do is I take few cc of BSS, 3-4 cc of BSS, and now I flush the BSS through the aspirating port. See this? I'm flushing it, and you can see there's lot of visco that sticks to the corneal endothelium, gets dislodged and comes out. Your flow is so gentle that it doesn't cause any cellular damage. So corneal endothelium never gets damaged by gentle flow of BSS towards the corneal endothelium. Now the case is antitumor is nicely formed. The integrity of the wound is checked and the case is concluded. Thank you very much for your attention. Hope this video will inspire you to develop your surgical skills.